All right, so we're at 12:30, so maybe we'll get started here. I have a bit of introductions, and then I'm sure a few people will trickle in as I'm making those. Um, so my name's Chris Plishka, and I'm the Methods Platform Facilitator at the Saskatchewan Centre for Patient-Oriented Research, or SCPOR, which is Saskatchewan's support unit under the CIHR Institutes for, or under the Canadian Institutes for Health Research, or CIHR's Strategy for Patient-Oriented Research. I'm very excited to be here today to hear from our presenters, Dr. Gary Groot and Dr. Jenny Basran. A note to everyone to ensure everything works with WebEx, please mute yourself if you haven't already been muted and turn off your camera to help ensure we don't run into bandwidth issues. If you have any questions or connections issues, please type them into the chat and a SCPOR staff member will assist you. Also note that today's session will be recorded. If that causes any issues for you, then please message Brittany Walsh and she'll help ensure that we remove you from the recording. Start off with, I'd like to take this opportunity to acknowledge that the event today is being hosted from Saskatoon, Saskatchewan, which is located on Treaty 6 territory. Treaty 6 territory is the traditional territory of numerous First Nations, including the Cree, Anishinaabe, Nakota, Lakota, and Dakota peoples. Treaty 6 territory is also the homeland of the Métis people. We recognize and understand that the relationship between SCPOR and the Indigenous peoples of this land is guided by the treaty relationship. Personally, my ancestors came to this area from Ukraine around 120 years ago, and I acknowledge that this may not have been possible if not for the treaties being signed at the time. I currently live and work in Treaty 6 territory, so I acknowledge that my day-to-day activities are influenced by the treaties that have been signed. Next, I'll provide a brief introduction of SCPOR. So if you're unfamiliar, then we support patient-oriented research in Saskatchewan, and we offer a variety of supports, including recruiting patients to be part of research teams, helping to fund students or trainees doing patient-oriented research. We provide consultations on engaging in patient-oriented research. We offer patient-oriented research training and training on how to build research relationships with Indigenous communities. We have a community of practice or a network of researchers doing patient-oriented research, and we call this the Affiliated Researcher Alliance. And we host learning events and workshops like the one we're having today. For information about any of our supports, you can reach out to SCPOR staff or visit our website at scipor.ca. Also note that today is the first in our series of workshops on learning health systems. As SCPOR starts to move into the second phase of our grant, we'll have a new focus on fostering a learning health system environment. I'll let our presenters provide a little bit more in-depth definition, but CHR defines a learning health system as an integrated health system in which progress in science, informatics, and care culture align to generate new knowledge as an ongoing natural byproduct of the care experience and seamlessly refine and deliver best practices for continuous improvement in the healthcare system. In preparing to support a learning health system, we plan to host a number of workshops over the next year to build a shared understanding of what a learning health system is and how it fits with the Saskatchewan context. So today is the first of that workshop series. So a quick overview of today's event. It'll start with a 30 to 40 minute presentation by our presenters, and that'll be followed by 30 to 40 minutes of questions and discussion. We ask that everyone keeps their microphones muted during the presentation and add their questions to the chat so that they can be discussed following the presentation. After the presentation, we ask that everyone either use the raise hand function, in which case we'll call on you and unmute you so that you can ask your question, or put the question in the chat and then someone from SCPOR will read it out. I'll quickly introduce our presenters and then we can get started. They both have some pretty amazing accomplishments. So to keep things to reasonable length, I've had to trim down their bios pretty substantially. So I apologize to Gary and Jenny for that. So Dr. Gary Groot currently holds a cross appointment at the University of Saskatchewan in the Department of Community Health and Epidemiology as an associate professor and in the surgery department as a clinical professor. He is a surgical oncologist at St. Paul's Hospital and is a physician co-lead with the Saskatchewan Health Authority's Clinical Excellence Portfolio. Gary is also the Director of Surgical Oncology in the Department of Surgery, Program Director of the Clinical Investigator Program in the College of Medicine, and Resident Research Coordinator for the Division of General Surgery. In these roles, he bridges the evolving needs of the healthcare system with his research interests. When the pandemic began, he assembled the COVID-19 evidence response team to rapidly search, review, and synthesize emerging evidence and render it relevant to policymakers. Dr. Jenny Basran is an associate professor of medicine and previous head of the Division of Geriatric Medicine at the University of Saskatchewan. She is Royal College certified in internal medicine and geriatric medicine and has practiced for over 17 years in both acute care and community care. Dr. Basran's research interests include incorporating geriatric principles into care across the continuum, computer modeling of the health system, and the use of technology to help older adults age successfully. She has participated in advanced quality improvement training from the Institute for Healthcare Improvement and Intermountain. She is the recipient of numerous grants with over 100 abstracts, publications, and presentations to date. In addition to providing clinical geriatric care and teaching, Dr. Basran is currently sharing the role of Senior Medical Information Officer for the Saskatchewan Health Authority. She's co-leading the provincial COVID-19 modeling with Dr. Osgood from the University of Saskatchewan. I'll now turn it over to Dr. Groot and Dr. Basran to get things started.
Good morning, good afternoon. I guess it's afternoon already, everyone. Dr. Basran, you're there somewhere as well?
I'm here.
Excellent. So we're going to try to not talk too much and just sort of give you an overview of some of the work that we've been doing. We've been doing them in a way separate, but they're connected and they've become more connected over time. And I think Dr. Basran and I share a common vision for a learning health system in Saskatchewan, and we'll see if we can share some of that with you. This is a definition that comes to you from the Institute of Medicine around what a learning health system is, and they would define it maybe a little bit differently than what you heard earlier, as a system where science, informatics, incentives, and culture are aligned for continuous improvement and innovation, with best practice seamlessly embedded in the delivery process and new knowledge captured as an integral byproduct of the delivery experience. Many of you will have already seen this diagram that I think is frequently used in presentations around learning health system, at least in Saskatchewan. And I would argue that this is conceptual. It looks simple. The reality is implementing it into practice is much more complex. And there's probably not just one learning health system. And Saskatchewan will need to figure out, and I don't think we're there yet, what a learning health system looks like for us in Saskatchewan. This is one of the pieces of that. This is sort of the meat, if you will, of the components of a learning health system that Dr. Basran and I have been witnessing unfold and start to come together with the pandemic. We're going to talk a little bit more about that. Jenny, we didn't discuss who was going to talk to which slides when we went over this the other day. Dr. Basran and I both went Intermountain Health in Utah some years ago and learned the beginnings or the framework of a learning health system back then. Did you want to speak to this? Or you want me to carry on?
No, you go. You're doing great.
So we took this course together with one of the premier founders, if I might say, in continuous quality improvement in the U.S. And one of the things I learned at the time, I didn't know, was that William Osler, who was a Canadian physician, actually started the whole movement of residency training as we know it now. He was the father of modern medicine in many ways. He restructured hospital administration and he established scientific research as the foundation of clinical practice. He formalized and standardized clinical education, and he set and enforced some pretty high standards for clinical practice back in the day. And I'm not, so I don't talk too long. His values, I think, still resonate today, and we kind of get trained in this mindset of professional practice, where an individual physician, be it Dr. Basran or myself, we can craft a unique diagnostic regime for an individual person, and that will result in the best possible result for each person that we see. And there's some core assumptions that underpin that compact, if you will, with society. And I'm sure that these core assumptions resonate with most people. The problem is that those core assumptions are no longer tenable. I suspect they might have been in Dr. Osler's day, but they're no longer tenable for a whole list of problems. And the pandemic's really brought that to the forelight, because there's our understanding of evidence is rapidly changing with COVID-19. And a lot of the evidence that we know is not actually applicable to individuals because of the fact that it works great in a controlled environment, but when you get out into reality, it doesn't. And moreover, there's so many other things that affect our decision making as professionals. There's lots of things that fit into the equation and result in whatever actions that we do. So Saskatchewan's actually invested pretty heavily in this whole concept of a learning health system. I think at some points it was called clinical quality improvement, but it's bigger than that, I think. And if you remember that first diagram from Menier et al., the bottom part was a bunch of pillars, and that Saskatchewan's invested very heavily in creating those pillars over the last 2 decades. But if anyone in the audience today feels this way when you think about a learning health system, I don't think that I could blame you. When the appropriateness of care program transitioned from the government into the health authority, I think the hope was that would solve all of the problems. And I have to admit, I don't think it did. And then the pandemic hit. And with the pandemic, it seemed in some way like things that were impossible became possible. Previously, people were ensconced in their comfortable little silos, and because of the pandemic and the necessity to address it, people stepped outside of those silos and started working towards a common goal like I don't think I've seen before. This is just me and my speaking. I'm looking at Dr. Basran. I suspect that you would say the same thing. And I think it took down a lot of the barriers that were preventing us from really starting to implement that learning health system. So I'm going to share with you a little bit about what my part in that is. Very early on in the pandemic, my co-lead in clinical excellence was asked to work with Mike Kelly to develop a COVID pathway because our pathways were part of the portfolio that we oversee. And so they got started on that, and I was sitting on the sidelines, and I just said one day, Mike, I know Mike very well. I said, Mike and Colin, was my co-lead. I said, is there anything that you could see me doing? And they said, well, could you do some of the evidence work for us so that we can focus on building this pathway? So I got a hold of Susan Shaw and Preston Smith, and I said, is it okay with you if I do this? And I was given a green light. And I have to admit, I was new in the health authority, and I had no idea what the different portfolios were and how they worked and what their jobs were. So I was kind of like a bull in a china shop, and I just pulled together a bunch of people from across portfolios, and not just cross portfolios. I pulled in people that I knew from the Health Quality Council and ultimately from the Ministry of Health, from Dr. Basran's portfolio, and we created an oversight committee and said, let's provide the evidence for the leadership as they need it. And since then, we've now done over 100 reviews. And the key of this being successful is actually the fact that we work together as a team. So the people that have been doing this work together, we would all agree. We didn't care what portfolio we came from, what place it was. It was let's get together and do this work. And a lot of it was done very rapidly in very short order. We created our own processes. This is one of them. But we had a whole bunch of processes we had to develop to have a standard way of doing these rapid reviews to give evidence back to the leadership. And early on in the pandemic, we saw our role as the input people. Like we would provide evidence as it existed and put it into this black box that was the policy decision makers, and then they made an output of some sort. But more and more over time, we have become invited to be part of the policy table as well, to provide input more real time. I also noticed that there are patient family advisors at those policy tables. I never saw that before because I wasn't at them at the first. And just recently, I had an invitation or a request from some patients who had actually put forward a request to volunteer to do exactly this kind of work that to the Ministry of Health, and so that's just been passed on to us. And I look forward to working together with patients in the community that want to be a part of this kind of work that we're doing. I'm going to pass it over to you now, Jenny.
Thanks, Dr. Groot. Yeah, so as Gary was referring to, there was kind of this urgent need to pull together multiple people and multiple teams to kind of provide some insights. There was rapid decision making that needed to be made, and a real principle to try to make it evidence-based and as informed as possible, understanding that it was changing so rapidly. So also early on in March, Dr. Osgood had already been doing some work on modeling COVID, because that was his area of expertise. And we just happened to be driving to Regina together at the end of February to talk about kind of the provincial data and analytics. And we were talking about this. And so, you know, sure enough, a week later at a system flow meeting, COVID came up, and suddenly there was this huge movement to really have a systematic approach to it. And Dr. Osgood was, you know, brought in very early and provided some insights to say, you know, we've got this model, we've been working on it, so we're already ahead of most other places because we've built a lot of stuff in there, and they've been collecting evidence as well. So very quickly then we partnered and decided to run different sorts of information. So at the very beginning, we used the evidence that was available to really try to figure out, like, what is this new virus that we know nothing about? How's that going to impact Saskatchewan? So some of the earlier models you may have seen out in the media were, what if we did nothing? What's the worst case scenario? Just to have a sense of, like, how many people are we talking about that would need hospitalization, things like that. And then over time, we built more and more into this model to really help bring in data that was being fed in, a lot of evidence and a lot of, you know, rapidly changing evidence from Gary and his team, bringing in an understanding from operational leads. So the questions for the models were provided by either EOC, which is our operational command within the SHA, or Dr. Shahab and the operational leads in the ministry. So the role then for analytics evolved as well, because we had our public health teams that were doing a lot of the public health epi. We started looking at some of the data and analytics on what was happening in the hospital, and then incorporating all of these pieces. And one of the benefits of dynamic modeling is that it actually helps bring all these various pieces together and does some of that complex thinking to provide some options and insights. And so a lot of work was really done to bring all of those together, put results out. And actually there is an oversight group that is ministry and SHA, and there's a technical working group that actually has quite broad representation that really refines the questions and takes the learnings and tries to say, like, what would we do with this? Can you look at it this way? So quite a integrated piece. And these, the modeling results are provided weekly and sometimes multiple times a week to help inform some of the decision making. I think the next slide is yours, Gary.
Yeah, so we thought that it would be maybe useful to give you a couple of examples of how the work that I did and the work that Dr. Basran did interfaced with some of the work that was done by the population health epi people to inform some of the difficult decisions that had to be made by our pandemic leadership, both in the SHA and with the ministry. So the first of those examples is the interval between the vaccination, the first and second dose of the vaccination. The initial trials came out and said you should vaccinate within a certain interval, and there were a number of people that looked at that, and the UK being the first one, and said, well, in order to get more vaccine into more people more quickly, we're going to recommend an extended or expanded interval despite what the evidence was. And actually, NACI just came out today, NACI being the federal scientific table, just around immunization, just came back out today with speaking out that they're still standing by their initial recommendations. But we did our own work here in Saskatchewan. I was asked to do, or our team was asked to do a review on how effective the vaccinations were, and this part of that was the question around the interval between these doses. The truth is there is a limited amount of evidence on this, and that evidence is slowly starting to mature, but at least at the time, there was limited evidence to make a definitive decision. But we did provide this evidence, and then we turned it over to Dr. Basran to do some more work.
Yeah, so there's several different types of models that are part of the University of Saskatchewan Supple Lab that Dr. Osgood leads. And one of them is a particle filter model, which is fed data every day on the number of tests done, positive tests, the number of admissions to hospital, who's in hospital, and if anyone has died. So that is fed in every day into this model, which then uses an artificial intelligence type of approach to understand what is really happening on the ground and gives us the effective reproductive number, which tells us how efficient the model or the virus is spreading. And that model is quite advanced. We're quite fortunate to have that in Saskatchewan. And part of the benefit of that is the data that we're feeding into it. So, and then the second piece of that is the evidence. So there are some assumptions built into that particle filter, which again are fed and updated with evidence. That model now is being used by PHAC to generate the effective reproductive number for every province in the country. And they actually don't have quite the same level of data because they don't have that direct link to the health authorities to provide that data and evidence. And the province benefits then from the evidence updates that Gary and his team provide. The second model that we use the most is called an agent-based model. And it's actually a replication of the entire province. So it has the number of people, where they live, demographics, where the schools are, where the hospitals are, long-term care facilities. And if you can imagine, it simulates activity, people going about their business. And then we put in different levers, like what percentage are wearing masks and what percentage are interacting in private gatherings. And we do all this type of work. And then the foundation of that is the assumption. So, you know, with the vaccine dosing, we can run a scenario to say, well, what if we gave everybody the dose 21 days after versus if we wait for 4 months? How many more people do we vaccinate? What is the impact then on hospitalizations, death, versus if we do it within 21 days? So those are the types of what if questions that can be run. And it's then provided specifically with Saskatchewan data, and the model is calibrated to our actual data every 2 weeks. So we calibrate to match what we think is the behaviors. Next slide, Gary.
And then that all the modeling work and the evidence reviews went together and went to an expert advisory panel that made a recommendation that made its way forward to the oversight committee. But we don't stop there. I mean, there's ongoing new evidence that informs what we're doing. There's the epi data. This is just one group of epi data that can be made available by our population health group and the epidemiologists. But we add that all together and we can see whether or not it's having the effect that we thought it was going to have. And if not, more adjustments can be made. Not only that, but there's new evidence that continues to emerge. So recently there's data from BC that suggests that people's immune response, if they're older or immune compromised, maybe isn't as robust and as long during as it might be with other people. And so maybe there needs to be some rethinking about the policy that was implemented. And it's not a static one-time thing. I think that's one of the real strengths of a learning health system is it's not a bunch of experts getting together and making a decision and then you forget about it. You constantly are looking at the evidence that says, did our decision work the way we thought it was going to work? And if not, you have an opportunity to review that and to modify it. So I'm going to go on to the next example, which is the thing that's in front of us all right now, the variants of concern. And some policy changes that might have needed to be made because of that. Once again, we were asked to do an evidence review, and here's a sort of the first page of a multi-page report that was put out. And I just want to point out that the number of people that were involved in the preparation of that included some researchers, some a number, in this case, a couple librarians, a couple peer reviewers being clinician experts that looked over it afterwards to make sure that it made sense, especially given the rapid pace of these reviews. And we have people with a variety of different expertise on these reviews that are working on it. And these people work together as a team. In this case, around the vaccination of concern, we get together on a weekly basis to discuss new and emerging literature to make sure that we're keeping these up to date. And then we passed it back off to the modeling team to do their work.
Yeah, so we built in both with this model, again, we run different what if scenarios. So in the model, we incorporate the evidence on, both what is the increase effectiveness as well the severity of the variants of concern, and each of the variants of concern are slightly different. So the model is built to be able to reflect that, and then we update those assumptions in the model based on the evolving evidence. We also then incorporate the benefit of the vaccination. So we, again, use the evidence to say, how good are each of the individual vaccines against the variants as well as the original wild type, as well by age group. So very detailed information from the evidence review is incorporated into the model. And then we add in the actual vaccination schedule. So what is the plan in Saskatchewan? And we simulate that, and we look at different options. So this was a model that we ran in early March where we said, so you can see the black dots to the far left are the actual cases. And we ran a simulation where we said, well, what would happen to ICU census if we opened up our gatherings on March 3rd and then on March 19th decided to either continue with the increased private gatherings, slow it down, or shut it down? And you can see there's a range of results because it simulates a whole bunch of different possible ones, and with the median line being the most common. And then this generally gave us a sense of what would happen, what could be the peak, and then how long would it take to slow down and shut down. And again, at this point, we hadn't introduced the severity yet. We were just getting evidence on that. So some of our more recent models have the severity. We have questions around, how long are you immune? And so those things are added in. And so again, this is an ever evolving model as well, but it gives them a bit of a sense of what to expect and what is the relative impact of different decisions. Then we take this and we try to translate that into something a little bit more simple. So Gary, if you could move to the next slide. And so this one was what we call our knowledge translation slide, where we took kind of the scenario that fit the best with our actuals, so the black dots being the actuals, and we actually modified it to what actually did happen, which was on March 9th, a new public health order was provided that increased the private gatherings. And we ran a what if scenario to say, well, what if on March 19th we realized, oh, maybe we need to slow down or shut down, or if we just want to continue. So the red line is if we continue, we can see increased demand in ICU census. And if you were to actually track this up until now, we're very close to actually what this model had anticipated. At that time, it also showed that, if you put in a public health order, it will actually continue to grow for several weeks because of momentum before there's a slowdown or shutdown. And so that was really important, I think, for the decision makers to understand that, you can't wait till the last minute when you're close to max to make a decision. So some of this is really important. I know Dr. Shahab says he uses this slide quite a bit, and we're just working on an updated one now with, we've done some comparison of the current public health orders as well as some further recommendations.
And again, it would have been ideal if we'd have had somebody from the EPI group to come and speak to a little bit of the EPI data. But I mean, once we have the evidence and then the modeling, the next step is to see and monitor what actually happens in our regions. And the EPI data gives us that sort of next step and allows us to see, did the things we thought were going to happen, did they actually happen? Do we need to rethink things? Do we have to re-look at the evidence, like what's going on? And this has been a continuous cycle. I mean, there's been almost weekly, actually, we get new evidence and we see what's actually happening. And it's from this data that we actually first saw that things were changing and the variant of concern was showing up in Regina, and that allowed us to then take that more even nuanced look about what's happening in different parts of the province, etc. I don't do
Well,
that.
Gary, I
Yeah.
was just going to say too that we use this data as well as the analytics team does some analytics on hospitalizations and number of people going to ICU, because the evidence, doesn't necessarily reflect what would happen in Saskatchewan. We have different clinical practices, different characteristics, geographies, and so we actually update the model then we fine tune it with Saskatchewan specific data to reflect exactly what's happening in Saskatchewan. So what is our length of stay? What are our clinical practices around who gets admitted to ICU versus but the starting point is the evidence review, and then we tweak it to reflect actual Saskatchewan data. So
Thanks,
it's a continuous cycle, yeah.
So just so you didn't worry that we were going to talk on forever, I'm just going to try and wrap up a little bit in terms of summarizing what did I learn about learning health systems. And probably the most important thing is if you go back to that one picture I showed you with all the characters going crazy, that's the way I felt probably a year or two ago. I was like, I'd put a lot of work and energy into developing a learning health system in Saskatchewan, along with many, many, many other people. I just felt like it wasn't going where I thought it would. And then with the pandemic, all of a sudden, like I said, what seemed impossible all of a sudden became possible. And I saw probably more than in the last 20 years, I saw the learning health system is possible. And the pandemic, I think, has shown us what it takes to do that. In many ways, I think we were our own worst enemies because of the silos we created and that prevented us from taking advantage of the concept of a learning health system.
And I think probably one of the biggest challenges and there's challenges and opportunities. So like Gary, it was really amazing to see that integration and recognizing the importance of all the players. There wasn't one that was more important than the other. You needed all of the puzzle pieces to work together to really provide that best learning, best informed decision making. And so there are challenges in all of them. There are challenges with our data. We're combining 12 different regions with multiple systems within each with we call it duct tape. We duct taped a lot of things together very quickly because of COVID. And so there's lots of issues around that. I think capacity across the board, whether it's in the modeling, the analytics, but across the system and in the evidence team, in the operations, that we really quickly saw the challenges with that. The ever-changing evidence and how we really did need to partner with the experts, whether they were clinical experts, families, patients themselves, the scientists, the researchers, and just a real recognition that our health system is complex. And for us, modeling was a tool that could help assist with trying to incorporate a lot of those pieces, but it really does require a full partnership across the board.
So just one parting thought around next steps and around the learning health system is that I think we would be wise as a system to learn from the pandemic and find ways to continue taking down the structural silos and connect the various relevant portfolios that provide evidence and the data support, including the foundational work that is required that Dr. Basran was talking about, and the analytics associated with that, and take that and merge it with the operational side of the organization. And I think if we do that, we have a real chance to have a functional learning health system going forward. I'll turn it back to you, Chris.
Thanks. Yeah, I'd start off with a big thank you to both Dr. Groot and Dr. Basran, not only for your presentation, but for all the amazing work you've done throughout the pandemic. I think Saskatchewan's very fortunate to have the two of you here helping out with that. We will take some questions from the chat. We had one that was submitted beforehand, or one or two, so maybe I'll start with that. And then it looks like a few are coming in for the chat. So the first question we got was, is there a concise way to define a learning health system to stakeholders? We often get asked what one is, and it's difficult to explain in a succinct way. So I think you probably touched on this at the beginning, but wondering if you have any other thoughts on explaining a learning health system to people.
You want to take that one, Jenny?
No, I was hoping you were going to take that because it is a good
Okay.
question.
It is, and I think, I don't know that, like I said, at the beginning, I don't think that there is one definition of a learning health system, but I think it's when you put together, I think the key ingredients are that you're using evidence, and your own data to come up with a policy, and then you re-examine your policy based on your own results and how it's working, and modify it accordingly. I think historically, when I think about the health system that I've been in, we've historically brought together a group of experts who would sit at a table and come up with an answer to whatever, and then they would implement it, and they would never look at it again, whether it worked or didn't work. And for me, it's about taking that and then implementing it, and then looking to see, did it achieve what you wanted to based on your own data, and integrating that data back into modifying it and continuing to improve it. And now that's not succinct, but
And I think to add to that too is, to Gary's point about, just getting a group of experts together that come up with an idea. Him and I have been in the system a long time, and lots of these types of meetings where even when you bring the evidence, unless you have operations, unless you have patients, unless you have some clinical people, you really, what you think should happen and how it should happen are very different. And one of the biggest learnings for me was even the data, like the sense that, oh, well, the data is great and it's good. Like you really do need the analyst who actually know how it was collected, what are the limitations, what are the challenges of the data. Like there's so many more people in that umbrella of expert that really need to be considered for it to be successful. I think the reason why a lot of previous programs failed or experiments failed, one, we never evaluated to know if they failed or not, but it was developed just with one siloed view of what should be done. And so I think the learning health system allows that continuous view, refinement, ongoing improvement.
If I could throw in one more thing, Chris, I know this is supposed to be succinct, and I'm not being succinct now. I also lead the provincial clinical quality improvement program with HQC. I'm the lead faculty for that. And one of the things we've done in Saskatchewan that I think is unique, and others might want to emulate, is that we have integrated the patient voice into all of the work that we're doing. And I think that's a strength of the Saskatchewan model. And like Dr. Basran and I were talking about, as we implement a learning health system, itself should be a learning system that continues to improve.
Perfect. Thanks to both of you. The next question comes from Candace Scrapic. So Candace, I'll read it out, and if there's anything you'd like to add, feel free to unmute and add whatever you'd like. So start off, thank you, Dr. Groot and Dr. Basran, for such an informative presentation about how a learning health system actually can provide rapid research and practice models. Key to successful implementation of a learning health system is the meaningful engagement of patient partners as co-designers and co-leaders. That will require a culture shift in attitudes and practices. Can you comment on how best to support and accelerate this engagement, and what role PRIMS and PROMs play in informing research and implementation in an effective learning health system?
I do think that it's a great question, Candace, and I think Gary's alluded to the health authorities' approach, I think, with COVID to ensure that we do have patients advise, and not more than advise, but actually are fully integrated. Both Gary and I sit on a lot of these policy tables now because of our roles that we play, and I think it makes a huge difference to the discussions, having our patients provide that insight. We do have, one of our executive directors is leading work specifically to make sure that we are incorporating and engaging others. I do think where we don't have as much work done is probably in the side of the prems and proms. There's right now a lot of decision making around like high level public health measures and looking at outcome impacts such as hospitalizations. There has been some work started to look at other impacts, but I don't think it's been fully developed. And I think that that's a very valid point. That is work that needs to continuously be looked at. I know there are researchers that are doing some of that. So where they have gone out and met with and interviewed individuals that have been impacted by COVID, or just how the population is responding. And that information actually comes back and is fed into both the models as well as some of that policy decision making. So I know that there are those pieces. I think probably one of the biggest learnings for me is really around how broad we have to go and how we don't have good ways to get input or data, like regularly updated information from large parts of the system, particularly out in the community.
If I could build on what you said, Dr. Basran, I would argue that at the same time as I say that I think the pandemic gave us a light to follow in terms of a learning health system. When the pandemic broke, I think we all fall back to the behavior we're most comfortable with. So involvement of patient family advisors on some of these policy decisions early on, I think was lacking. I don't think that's the case anymore, but I think it was because we fell back to our normal way of being, and that we've made a course corrected on that, I think. But there are very important areas that where patient family advisors were critical to informing policy, especially with long-term care and the pandemic response in long-term care. We have had a team with our evidence group that were connected to a pre-existing provincial team that included a lot of families, and I think that helped them with shaping their reports, and that then in turn shaped a lot of the decisions that were made. And I think they had it right from the beginning, even if I didn't see it all the time. And there was work that I know our team was working on with prems and proms in conjunction with Health Quality Council, but it sort of it didn't take the forefront. The forefront of the work was just trying to get things done because of the urgency. So there's things to be learned, and it'll be interesting to see an evaluation of the whole rollout and how we could have done things maybe better at times. But I think those things have been incorporated to some extent, and maybe we could do even better going forward.
Thanks, and I'll add PRIMS and PROMs are patient-reported experience measures and patient-reported outcome measures, because I know at SCPOR we try to avoid as much jargon as possible, but we still fall back to it sometimes. You can't really have a healthcare presentation without some jargon, is always my joke. Our next question comes from N. Newman. And once again, feel free to jump in if there's anything else to add to the question. Do you have any advice on how to get buy-in from healthcare leadership or executives for the learning health system model? Thoughts on how to talk to them about it?
Well, I can tell you that I had a conversation very recently with Dr. Susan Shaw and Beth Vachon, and I am pretty convinced that the buy-in is there and their understanding is there. The actual doing of it is harder than you might imagine, but I am convinced that they do get it and the buy-in's there.
I think I would agree with Gary. I do think that there was already kind of work within the SHA about understanding and meeting the incorporation of data and evidence and quality improvement. I think their mind was already heading that way. I think COVID cemented that, and now it's the work of sorting that out. I do think there's still some challenges beyond that. Many of our we could provide recommendations, but there are other contributors to decision making at the ministry level. So I think getting beyond the health authority broader, that will take some time because there are other pieces. We're talking about a learning health system and not necessarily a provincial. I don't know what I want to call it, but I think you guys know what I mean.
Perfect, thanks. Next question comes from Fiona Fick, and her question was, thank you for the very informative presentation. Having created a pathway for integration of evidence into decision-making around COVID, how would you suggest going about this with other areas?
I think that's an excellent question, and one that we've talked about lots.
So, I mean, a very good question, Fiona. I think that what we did, we pulled together in fairly short order, and it's fairly labor intensive and dependent on a small number of people. I mean, if I had my choice, I would maintain a structure that's consistent so that there's a way that we do it in Saskatchewan that is evaluated and improved upon continuously, but that is then taught to and applied to a whole host of other things and other important questions in the healthcare system, but led by the people that actually do the work.
I think that there's lots of areas too that this can be applied to. Certainly system flow is one, and we did kind of almost a mini version of this with the ED-Wait patient flow, where we tried to incorporate lots of different pieces of information to inform kind of the development of the connected care system. The difference then was it was 12 different regions, all with different priorities, all with different structures. And I think the COVID example has shown how by working together, we can really do that. I think the next areas partly will be dependent on, priorities of the health system, but also availability of information to be able to be fed into different decision-making processes. And as you know, if it was up to me, it would all be about geriatrics.
So I think that ties in really well to our next question that comes from Esther, and I'm not sure how to pronounce your last name, so apologies for that. Again, thank you for the presentation. How would you then deal with the issue of data collection for the purpose of learning, and what have you learned?
I learned that it's a lot of work. So, we want a balance of data collection that doesn't create burden for the best data is data collected at the front lines at the point of care, but we also don't want it to be a burden. And one of the things that we have found is, the data that we need is so crucial to informing decisions. There's a lot of variation in that data. People are rushing, people are trying to get stuff done. They've got multiple things they're struggling with. It could be understanding. So within the digital health portfolio, a lot of work has been done to look at how do we make this as easy as possible? What can we pre-populate? What can we stream from one place to another? But it really also highlighted for us just how different, all 12 health regions define their data differently, collected it differently. So even though, we have bad data and high data and all this, nationally reported data, there's still a lot of variation in there. And so when you're using it in a learning health system, you want to make sure that those are collected the same and defined the same. And so I think as we make priority decisions, we're going to have to start with a subset and work through that and really create all that. And where we have the biggest gaps is data outside of the acute care system, right? And so a lot of work will have to be done there. And part of that is integrated technology, so one clinical information system rather than multiple different ones, but also a really good basis to define and standardize that data without making it a burden to the front line. So those are all key principles, and we did some quick learning around that, and I think that will keep applying as well.
The one thing I relearned, Dr. Basran's the data guru, so I can't top her at all in any of her understanding and knowledge of the data. But the one thing I relearned was something I learned from Brent James at Intermountain, which was data is essential, but it's complex and expensive. And so there's no room in this for recreational data. Yes, you collect the data you need to collect, and there really isn't time and energy to collect data just for the fun of it.
All right, our next question comes from Sinead McGartland. What governance models need to be in place for learning health systems to be effective? Where are we set up to achieve this? Where are the learners and academic institutes?
There's this thing called SASHN, which is the Saskatchewan Health Network. I forget what an acronym entirely stands for, but it would be a governance table that includes academia and the health authority and the government and all those players at the same table. And I think that's probably something like that is the right governance table to oversee this at a high level. Because everybody needs to be at the table, including patient families, including Health Quality Council. Like there's a number of very important players that need to be there. eHealth. I'm going to miss some people, and forgive me for whoever I forgot. But yeah, it's some sort of a higher level governance table will be required for that.
Also, there has been work over the last year or so around provincial data and analytics. There's a secretariat in place with a team that really is there to help try to apply a provincial lens to some of the priority work. So I see there being, quite a bit of overlap between those teams and potentially another area of identifying, governance possibilities. It's so challenging, right? Because everybody, it's a great model and you want it applied to everything, but there's it's going to take work and effort and time, and there have to be some decision making around where are our priorities, where do we start with, where do we go, how do we ensure that we're balancing not just operational needs, but academic and learning needs, as well as ensuring that we are making tangible improvements for our patients and families. So, we want to make sure that all of that's covered off. I think if you pull it more one way than the other, you skew it. So we really want to make sure that all those needs are met as we apply the learning health system moving forward.
And SASHN would be Saskatchewan Academic Health Sciences Network, I believe, if anybody wants to look into that more. So we have 7 minutes left and 2 questions, so we'll see if we can get to both of them. Our next question comes from Rosalind Compton, who asks, what about applying this approach to long-term care? When will we see a learning health system implemented for long-term care to address the human rights and well-being of older adults living in long-term care and their families or persons of choice?
Well, Rosalind, if it was up to me, that would be happening right now, and we would just be going there. But I think, again, to that question, I do think that the whole question of older adults, I think COVID has really highlighted what many of us knew were challenges in the health system for our most vulnerable, particularly older adults. And so I do think that will definitely be an area of consideration. Part of our challenges, again, will go back to both the data and availability and creating those structures in place. But I think that is definitely one area that has been really starkly brought to our attention. Last weekend, I read Andre Picard's book, and I read it in one sitting, and it just got me all riled up again. So, I do think that it's on the radar for many of us. And would probably be one of the areas under consideration.
And I apologize, we go till 2, so if there are more questions, then keep them coming. We do have time to answer some more questions or open up some more discussion. So our next question would be, research is often a hard sell for a healthcare organization that is not linked to an academic center, yet it is part of a learning health system. How do you incorporate research into your learning health system, and any advice on promoting research or the generation of new evidence, as well as the use of existing evidence within an organization?
I'm not sure who asked that question, but thank you. It's almost like it was planted for me. Um, I actually came to research very late in my career, but I really have changed my view on research. I think that Saskatchewan can and should be as much a generator of research as a consumer of research. And I think this whole learning health system, what it does is as you move along, you start to see the gaps where research is needed. You can start with evidence, like the evidence reviews we've been doing, and then you policymakers will make a decision. You say we want to do this, but as you start to do that, it becomes obvious where their gaps in knowledge are, and that's the place where research needs to step in. And to me, it's a natural fit. The two of them go together. Research is going to be most impactful and most useful if it's actually focused on the needs of the system. So I can't imagine a learning health system not connected to academia. It's sort of the bread and butter.
Well, and I think it also it ensures that different degrees of or different approaches are applied to the understanding. So there is, right up to your randomized control trials, but a variation in different types of research. And I think, and I've long said this, that Saskatchewan is also very poised to be leaders in that field of implementation science, because we have a lot of clinicians that also do research, unlike some of the larger academic centers where the researchers have minimal clinical work. And so here we have a setting for that, and we've built over many years this idea of quality improvement and data. So our operational leaders are also they understand concepts of quality improvement and lean and how to take data and continually improve and incorporate evidence and generate evidence. So I do think that we're poised for that. It's just really around, for me, it's around building capacity. Like, I think from the modeling point of view, we would be reading all these modeling papers that were coming out, and the models were nowhere near as well developed as what Dr. Osgood's team was able to develop. And we just never we didn't even have a moment to think about publishing any of that and putting it out there. And it was really unfortunate, because we had some really significant learnings that probably could have helped other people, but we were able to share them at the PHAC modeling table. But beyond that, we didn't get, our model is now also being used in Australia, and so we are able to share that way. But when I think about a research point of view, there's so much. It's just really about building that capacity. And I think with Gary's role and his interest, I think that that's part of it. It is that it's not separate, right? Like, the researchers aren't after the fact looking at data and then trying to, interpret and generate differently, or coming up with separate ideas and then trying to get the health system to adopt it. It's really about bringing those together and doing it in real time moving forward.
And just in response to Fiona, because I see she put something in the chat there, I completely agree with you, Fiona. Research in my mind is much bigger than bench research, which is important, or even clinical research, which is important, but it includes organizational research, evaluation, et cetera, et cetera. I mean, that's a learning health system should be learning itself as it unfolds and improving and doing better. And that's part of a learning health system.
Yeah, so our next question would come from the SHA library. And the question would be, have there been discussions about the First Nations organizations that provide health services to be part of a learning health system, or how are they being brought into this?
So I can just say that as a part of, and again, not everything came off perfectly at the get-go necessarily, but I think the various First Nations Métis organizations that are in the province and the First Nations Métis Health within the SHA have been at the table, at the policy table with much of the pandemic, and continue to be. So I think they are a part of a learning health system as much as patients and families are a part of a learning health system, as much as clinicians are, as much as administrators are, and as much as the government is. They all need to be strong partners in a learning health system.
I want to give an example of like some of the work that we did early on. So many of you will remember that one of our first big outbreaks was in La Loche Clearwater. And so we actually built a model specifically geographically representing that area. And in there, we included things such as housing density, the increased risk due to chronic disease, so different dynamics that were unique there. And we actually worked with the MHOs that work in that area, as well as several of the leads. So leads being, the council chiefs, different educators. And we actually worked together to build this model and asked the questions that they had to build. And then they took our modeling results and went back to the community and used those results from there. And we had brought in evidence specifically that was reflective of the higher transmission and different things like that. And we were able to take that, generate the result, and the leaders actually took it back to their community and used it as part of knowledge translation to get increased uptake of mask use and understanding the importance of testing. And in there, they were very successful at bringing that outbreak under control. And if you listen to, the presentations, they will often talk about that ability to take some of that information and use it to bring it back to the communities to understand, why we have to do different things. So to me, it was a really great example because the loop then went right back to the individuals in the community. It wasn't just to help inform operational decisions. So I thought that was really a great example of that.
And if I could loop back to a conversation we were having just a few minutes ago, that work that was done in La Loche Clearwater, in my role at the SHA, we were asked to do an evaluation of that so that it could be used by other communities, not just in Saskatchewan, but elsewhere. And we're in the middle of doing that right now, where we're doing a research project looking at that whole rollout and what happened there, as well as the economic side of that, in collaboration with First Nations Métis Health, the local communities, both Clearwater and La Loche, MNS, NITHA, etc. And so that's turned around into a small research project that we hope will be a value add to all those communities.
Perfect. I see Jason has his hand raised, so I'll go to Jason Vanstone next.
Thanks. Thanks, Dr. Groot and Dr. Basran, for a great presentation and some great discussion here. It's great to hear all these ideas and questions coming from people. One of the things I wanted to ask is, and I think because in your presentation, it really resonated with me about some of the things in our world that our team in stewardship and clinical appropriateness has faced. And so obviously with the learning health system, we've talked a lot about sort of that front end piece of front end, if you will, depending on how you envision it. But you need data, right? You need data and information to start to drive the change and to give people the information about where there is room for improvement. And then getting leadership involved and understanding getting all the systems together, right? There's a really complicated piece there, but equally complicated is the back end of that, and that's the actual implementation of the behavior change and getting people involved. And so, I've seen this multiple times where we in our group we pull the data together and you present it to people and it just kind of falls flat, or it just struck me with your Dr. Basran, you're showing the models, right? And you see, if we don't do anything, this is what's going to happen. And you present that stuff to the people who have the ability to make the changes. And to date, it seems they haven't done anything. And so we're following along what is, it's like you have the information to make the changes, but we don't see that happening. So I guess my question or comment or request is, can you guys talk a little bit about, I guess, the importance of that implementation piece and getting the behavior change and getting leadership and the structures in place in something like the SHA to actually get the boots on the ground, so to speak, or get that change to be integrated and sustained within a larger health system?
Yeah, good question, Jason. I know certainly when we first put out the modeling, people were very unsure about it. We still get comments like, "Oh, it was really wrong," and we're like, "That's good. That means they listened." We clearly took action last March, and that's why we didn't get those results. Even our results in the fall, they waited maybe a little longer than what we recommended before they made those changes. I would say that SHA operations really follows the idea that the evidence is incorporated with the data and the modeling. I think SHA follows it and is following it very closely and making changes weekly based on that. I can't speak, at the ministry level, there are more than just, I guess our considerations that are being taken into to make those decisions. I know Dr. Shahab strongly is involved in this and is using some of that information. I think you ask a good question around larger behavioral change is important. One of the things that probably got us the most people on board was that, with our models, we started tracking. Well, here's what our model said, and here's where the actuals are. And we just kept tracking, and it showed that we were tracking pretty close, if not right on what our models had. And normally it's not often that clear, but our team is really great, and we really have calibrated to Saskatchewan data. So it wasn't just random, what if you apply this evidence, you should get this. We actually calibrated it and fine-tuned it to those questions. So part of that implementation, I think the success is the feedback loop, right? Is it making a change? Is it showing this difference? Is it coming down? What's happening? So really, rather than just saying, here's what we think you should do, having that ability to feedback and say, is it working? Is it not working? What do we have to adjust? So we will get questions. One of the benefits of the modeling is, unlike a statistical model, which I think other places have used, we can actually say, what's the relative impact of each of these levers? So then we can say, okay, what if we tighten this up a little bit? Or what if we just assume people, only a certain percentage of people are going to wear masks? Then what if we did this instead? So it allows that back and forth so that you're not just kind of like, well, we know all of these things are supposed to impact, but we don't know which one it is. So the modeling allows some of that. So that feedback loop, I think, is probably how we got SHA on board. I would say that they're very much in tune to kind of the results of, because they know it's informed by evidence that's continuously updated. They know it's fed by data and adjusted by our actual local data. And they know that the models are calibrated and updated. And then we have that feedback loop. But as far as the ministry, I can't speak to, other decision factors that are, you got it.
I'm going to answer your question, Jason, if I might, with a bit of a future lens, because I think that we're set in a good way, and there's a couple things we could do to improve on that to be successful with the learning health system in Saskatchewan. Where the Saskatchewan Medical Association has reached an agreement with government to provide ongoing funding for the CQIP program, the Clinical Quality Improvement Program that's offered through HQC. Which is an opportunity for clinicians to learn not just the tools of a learning health system and understanding how to use data and how to understand that data, but also how to do the implementation science, how to do the behavior change, and how to have that kind of leadership. We have quite a few graduates from that now, and we'll continue to graduate and increase capacity. I think that maybe in the near future is a good time. We're moving into our 5th cohort soon. It'll be hopefully in September if we keep this under control. I think it might be a good time in the near future to sit down together, those of us that are doing this, including yourself and others, and look at that curriculum so that we're all teaching the same thing. We're thinking the same way as we move forward. And then the other half of that is, like with the learning health system, like I've said before, I think it'll be on us to continue to look at the results and the impact of what we're doing and refine it and incorporate new learnings around implementation science and what motivates people to do what they do. So building that capacity in the system in a way that we do it in Saskatchewan, and being open to continuing to improve that system as we put it in place. So I think that combination will serve us well, and we have the capacity to do that, and I think we can and should.
Thank you both.
All right, we have another question from Candace Scrappick, who says the Saskatchewan Council on Aging, or SCOA, is a CBO that focuses much of its work on promoting the well-being of older adults. We've all seen the devastating impacts of the pandemic has had on this population. SCOA is working to address these issues. How do CBOs connect into or benefit from the learning health system to help drive addressing what actually matters to patients and families in their community?
I love all these questions about older adults.
That's why you answer them.
I think that that's probably, to me, where the evolution of the learning health system has to go, because data is a big part of that, and most of our data currently is acute care focused data. I think we need to really have that lens of, and I think, our province going to a connected care system and really understanding that, care is more than just your hospital visit. It's even more than just your primary care visit. It's your environment and your community. So I think if advocacy, other pieces, if we can build and expand the learning health system, it's almost like a learning wellness system, to incorporate other contributors to our health and wellness, and then thinking about how do we bring that in there. So, there's growing evidence on, particularly for older adults, around social isolation and how to prevent or slow down dementia, things like that. So growing evidence coming, but we don't have the data. We don't have a lot of that community-based data, and we really do need to focus on trying to figure out how to bring that in, and then linking it to then, what we have as an understanding of acute care and long-term care and other pieces. So I think it's exactly, complex care is exactly what a learning health system was meant to really help with, right? It really is looking at that longitudinal view, but our biggest challenges is the data, both just data, how we're accessing different things, but also, as you've mentioned earlier, around the prems and proms, some of the important outcome measures that we're not collecting.
If I could add on that, this isn't the question, so I'm not going to answer your question. I'm going to use it as a springboard to even more questions, which is the same thing could be applied to other community groups and seeing what are the needs in community and are we addressing them. And I'm thinking specifically of some of the work that my team has been doing with First Nations, Métis Health, and Indigenous Health. And it's exactly the same question. Have we successfully, and I would argue we haven't, have we successfully as a system captured the needs of people in the community? Do we understand things through a lens that are not just acute care focused? And I mean, those of us in the system often, that's what I operate on people in with cancer. And so my primary focus tends to be on what I do. And so we need to find a way to connect to community to understand that what we do is actually what's needed most by the community, because that's what we're ultimately about. And I think there's work to be done there, and I think it's important.
I also, one more piece, part of the federal transfer dollars was funding for something called the Shared Care Plan. So some of you have heard me present before, have heard me talk about this. And this is really about an integrated care plan that moves with the individual throughout the system and is driven by the patient's goals. So we did get the funding, and there is some work starting over the next year or two to look at, what would it take to do that? And that really is probably an opportunity for us to start incorporating, specific patient goals into a format that can be measured and collected, but also looking at different outcome measures throughout the system beyond just what's in acute care. So I think it's exciting. I don't think anyone else is doing anything like this. And so we're quite excited that Saskatchewan did get some of the funding to move ahead with that. And that's work that I co-lead. So we will be bringing it into, that lens into the learning health system as well.
One quick question I think that was directed towards Gary from Lynn Fian. Can you share the link to the training curriculum? So I assume that's the one you were discussing earlier, Gary. And if you want to provide that after the presentation instead of searching it out now, then I'd be happy to send that around. And then a question from Ray Lalaberty. Excellent presentation. How does Saskatchewan residents ensure we don't go back to the old siloed healthcare system once the pandemic improves?
Raymond, it's like you've been around a little bit. Good question. Gary?
Well, I mean, obviously, neither Dr. Basran nor I have the power to make that happen, but we have some influence. I think my own bias, and I've talked to people in leadership. I've talked to, like I said, to Susan Shaw, Beth Vachon. I've spoken with Dr. Basran. I've spoken to some of the pandemic leads, and I think people see the same thing we're seeing. So what we're talking about today is it's not just the two of us that are seeing this. How do we then take those learnings and move it forward? I think that the single health authority was pretty new. It was 1 year in, and I think the people that created that structure were thoughtful, and it was a good starting point. I think it's time for the health authority to look at that structure and find ways to now integrate all those different portfolios that were a little bit disconnected, and take advantage of the learnings from the pandemic. I think the first thing, anytime I've learned something in my life, the first thing is to actually be able to say, I see that. And until you see it, you can't change, right? So I think the aha, we've seen that has happened. And I know I will continue to leverage what I can to find that integration across the various portfolios of the health authority and the operational side. And I suspect others will as well. That's not a real answer, but maybe it's a start.
I do think that the COVID has really changed even, how people talk. So, even though because we were new, there was still like, well, we do this in Saskatoon and we do this in Regina, or we do this in digital health. And so we're not hearing that. I don't hear that hardly at all anymore. I hear very much like we, the SHA, are doing this. And then it's really about, we're one system. And I think that in itself is a huge step forward. It was a painful way to get there with COVID, but I think it advanced our maturity with that. And I think that allows us then to look at how do the individual pieces of the SHA then start working together. So I think we're closer than we were before COVID.
And another really great question from Melody Isinger. During the pandemic, the questions drove the research and identified what data was necessary. The entire health system was focused on one cause. Will this process hold for identifying needs post-pandemic? Who will set the agenda for the learning health system?
With such easy questions, eh? I don't think the structure's in place yet, but I think there's an understanding that there needs to be a table that does that includes patient family advisors, health quality council, cancer agency, ministry, education, like the educational institutions, the SHA, and that will probably be that table. It hasn't been created that I'm aware of, but that doesn't mean that it hasn't, just because I'm not aware of it. But it'll be something like that that'll be needed to set the agenda of the learning health system.
Yeah, and it will have to come that way. Like whether, as I mentioned, I know that there is, different groups that have been looking at either learning health systems or data analytics. And, you know, it will, you know, like Melody is saying, for it to be successful, all the parties have to be in agreement that whatever the focus area is the focus area. And that's going to be a challenge because, you know, there are many priority areas that need to be addressed in our health system. But for it to be successful, we can't have a little bit here and a little bit here. We really do need some focused ability to bring the different people in and get that first successful system set up, just like we did for COVID, and then continue to expand it from there. So hopefully those wiser than us, Gary, can make sure that happens.
And apologies to both of you. I don't think we gave you any softball questions that were easy to answer yet today, so putting you on the spot.
They're the fun ones, though, actually.
So that's I'll have one more look through the chat, see if there's any hands raised or questions that have been asked, but I think that we're starting to get to the end of them. So I'll give everybody one last opportunity to either raise your hand or put something in the chat. All right, if not, I think we're actually coming to close to the end of our time now. So yeah, I'd like to start by thanking both our presenters today, and I see a few hand claps from the audience. A few people saying thank you for the excellent presentation in the chat. Also want to thank all the attendees for coming today, and thank you to Brittany Walsh from SCPOR for all her work managing things behind the scenes. It was, I think everything went smoothly. So thanks, Brittany, for your work there. Just a heads up to everyone, all attendees will be sent a survey following the event. We love to get your thoughts and feedback on how things went today and how we can improve for future events or what everyone wants to see from future events. So please complete the survey. It'll only take a few minutes. And that concludes the workshop for today.
And I'd like to thank SCPOR for inviting us and for opening this dialogue. I think it's a really important dialogue, and it's great to see so many people that have an interest in it.
And really great questions. So thank you, everyone.